Por favor. Con el deseo de ir cumpliendo el apretado programa que tenemos por delante, les ruego que se vayan sentando. Buenos días. En primer lugar, darle la bienvenida a este aula magna de la Facultad de Medicina. Como decano y como presidente del comité organizador de esta reunión de la Sociedad Española de Epidemiología, es para mí una satisfacción enorme, y para todos los que hemos trabajado durante este año para preparar esta reunión, poder estar aquí hoy contando con su presencia. Estamos enormemente satisfechos del atractivo que ha tenido esta reunión, con más de 700 inscritos, con personas procedentes de todas las comunidades autónomas de Portugal, representantes de Argentina, de Brasil, de Chile, de Colombia, de Ecuador, de México, de Paraguay, de Perú, y en el entorno europeo, personas procedentes de Albania, de Alemania, de Bélgica, de Noruega y del Reino Unido. A todos, bienvenidos. Esperemos que sepan disculpar los errores, los fallos que tengamos durante la organización de estos 3 días, porque detrás de todo eso lo que hay es un enorme interés por disfrutar y por contar con todo el trabajo de los ponentes y de todos los participantes. Quería, por ser breve, también dar una pequeña nota del programa. Tenemos interés en el Congreso de la Sociedad Española y de la Asociación Portuguesa. Se celebra también en colaboración con la Universidad de Sevilla y la Consejería de Salud, y queríamos contar con los representantes de esas dos instituciones. Motivos de agenda del consejero de Salud, que tenía un enorme interés en participar en la inauguración, impedían que estuvieran en este momento aquí con nosotros. Por eso el acto de inauguración se hará a partir de las 2:30. Rogamos ser muy puntuales. Nosotros vamos a intentarlo desde la organización para interferir lo menos posible en el normal desarrollo de las mesas y sesiones de póster que hay a partir de las 3 de la tarde. Y sin más, le paso la palabra a la presidenta del Comité Científico, a Soledad Márquez.
Hola, buenos días a todos y a todas, y bienvenidos. En primer lugar, quería decir que la presidencia del Comité Científico este año ha sido una presidencia compartida entre José María Mayoral y yo. Por circunstancias imprevistas, José María no puede estar aquí hoy, pero creo que es de justicia reconocer todo el trabajo que ha puesto este año y toda la ilusión que ha puesto en este congreso. Bueno, quiero empezar por agradecer a la Universidad de Sevilla, a la Consejería de Salud por su apoyo, por supuesto a las 2 sociedades científicas que nos han dado su confianza a los miembros del Comité Científico. También a la Dirección General de Tráfico, que un año más ha apoyado económicamente y también participando en las actividades científicas a este congreso. A las profesionales de GISECO, que han sido una ayuda inestimable para el Comité Científico, especialmente a María Ortiz, a May. Y bueno, pero sobre todo a todas las personas que habéis enviado las comunicaciones, porque de alguna manera este congreso, el Congreso de la SE, es un congreso que se hace, de alguna manera el programa lo decide la gente, porque lo deciden las comunicaciones. Sabéis que tenemos muy poquitas sesiones plenarias, un espacio diario solamente, y todos los demás son los trabajos que habéis enviado. Y como diría Fernando García Benavide, la cosecha del año, que ha sido una buena cosecha de la epidemiología de España, de Portugal y de otros países, como ha dicho Juan Ramón. Brevemente deciros que hemos recibido más de 900 comunicaciones, se ha aceptado el 95% de ellas y se presentan, por tanto, 879 comunicaciones en el Congreso. Participan prácticamente todas las comunidades autónomas, Andalucía este año con una participación especial, como es lógico, una de las primeras, Y bueno, pues tenemos 17 mesas espontáneas, 41 sesiones adicionales de comunicaciones orales, 29 de póster, es decir, que tenemos un programa muy apretado que a veces ha sido difícil poner en una misma franja horaria temas que no se solaparan demasiado, ¿no? Es difícil. Por áreas temáticas, el área con más comunicación es la de brotes epidémicos y crisis de salud pública, seguida de cáncer, evaluación de servicios sanitarios y tecnología, desigualdades en salud, salud ambiental y tuberculosis. Bueno, en la Gaceta Sanitaria, que ya la tenéis online, tenéis más información de todo esto. Y simplemente por dar una pincelada, solamente hay una sesión plenaria diaria. Hoy vamos a tener la suerte y el lujo de contar con la profesora Clare Bambra de la Universidad de Durham y que nos va a hablar de epidemiología política. Mañana vamos a tener 2 sesiones simultáneas. Esto ha sido una decisión difícil del comité científico, pero nos ha parecido que eran 2 temas de mucho interés y serán sesiones semiplenarias, por tanto. Una mesa sobre información epidemiológica al servicio de la salud en todas las políticas y otra sobre procesos migratorios forzados y los retos que supone para la salud pública. Y por último, en la clausura contaremos con Ildefonso Hernández, que hará la conferencia de clausura sobre la calidad de las instituciones y los intereses en juego en la salud en todas las políticas. Y sin más, pues bienvenidos y gracias a todos por la participación.
En representación de la Asociación Portuguesa de Epidemiología tiene la palabra Enrique Barros.
Buenos días, muchas gracias. Vou falar-lhes em português. Queria, em primeiro lugar, agradecer muito à Sociedade Espanhola de Epidemiologia o fazer este caminho com os portugueses, esta partilha de trabalho, de investigação, de apresentação, tem sido muito, muito importante para o crescimento da epidemiologia portuguesa. Por isso, uma vez mais, em meu nome pessoal e em nome da Associação Portuguesa de Epidemiologia, muito obrigado. Queria saudar os companheiros espanhóis, portugueses e de outros países que estão aqui presentes e dizer-lhes que também, porque represento a Associação Internacional de Epidemiologia e a Federação Europeia de Epidemiologia, dizer-lhes que, em nome delas, muito obrigado por todo este trabalho, pela enorme qualidade desta organização e seguramente pela grande qualidade das discussões e das apresentações que irão ser feitas ao longo destes dias. Muito obrigado.
Finalmente tiene la palabra Esther Fernández por la Sociedad Española de Epidemiología.
Muchas gracias. Bueno, por suerte hay pocas cosas que añadir. En primer lugar, muchas gracias, muy obrigado por las bonitas palabras que acaba de tener Enrique Barros y por, evidentemente, la colaboración de la Asociación Portuguesa de Epidemiología en este camino, que eso es importantísimo, y sencillamente recordar eso, el trabajo que ha llevado hasta aquí, que han llevado de manera magistral desde el comité organizador, Juan Ramón y todo el equipo del comité organizador, sin cuyo esfuerzo pues ahora no estaríamos empezando a disfrutar, porque todavía nos queda mucho que disfrutar durante estos 3 días, así lo esperamos todos, y evidentemente el extraordinario y fantástico trabajo que está llevando a cabo, que ha llevado a cabo y que ahora recogeremos todos esos frutos por parte del comité científico. Yo quiero aquí, desde en nombre de la Sociedad Española de Epidemiología, dar las gracias ya, también las daremos mañana y pasado y en la clausura, evidentemente, porque es importantísimo tanto a Solejo como a José María por todo el trabajo y a todas las personas que han colaborado con el comité científico directamente o como apoyo a los revisores, etc. Los agradecimientos son inmensos, estamos empezando, después tendremos una presentación oficial del Congreso con otras autoridades, pero yo creo que estamos ya en la dinámica, velocidad de crucero, la sala está casi llena, evidentemente es difícil ir a todo y no voy a entretener más. Gracias a estar aquí, a todos, gracias a los que habéis hecho que esto sea posible, y vamos ahora a disfrutarlo entre todos, a aprender, a compartir y a seguir trabajando por la epidemiología y la salud de nuestras poblaciones. Gracias.
A continuación hablará Carmen Vives para presentar a la conferenciante.
Buenos días a todos. Tras esta breve bienvenida de los presidentes del Comité Científico, organizador de la Asociación Portuguesa de Epidemiología y de la Sociedad Española de Epidemiología, voy a pasar a la presentación de nuestra ponente invitada para la conferencia inaugural de hoy. Antes, como miembro de la Junta de la SE y también como socia, quiero reiterar los agradecimientos muy especialmente a los miembros del Comité Científico y organizador, porque, bueno, por la dedicación que habéis hecho a lo largo de este año y también por las buenas decisiones que habéis tomado. Entre ellas me gustaría destacar la decisión de haber invitado a nuestra ponente y también la elección del tema que habéis realizado. El tema de la ponencia, de su ponencia sobre cómo las políticas y la toma de decisiones políticas afectan a la salud y pueden acabar provocando que las personas se enfermen, es sin duda un tema relevante y de actualidad tanto en España como en otros países, incluyendo Gran Bretaña, que es donde procede nuestra ponente invitada. De hecho, hace poco salía en la prensa una propuesta para poder corregir los retrasos en la espera, ¿no?, para intervenciones quirúrgicas, y hablaban de una posible exclusión de aquellas personas, de algunos grupos poblacionales por su consumo de tabaco o por su peso. Ese tipo de decisiones tienen sin duda efectos inmediatos porque afectan a la salud de las personas directamente, por lo menos a aquellas, ¿no?, que están señalando en esas decisiones, pero también a largo plazo, relacionadas con las desigualdades sociales, cómo construimos socialmente el problema de la obesidad y el tabaquismo y el propio sistema de gestión de servicios de salud. Nuestra ponente invitada es Clare Bambra. Ella es profesora, como se ha comentado antes, de Salud Pública en el Departamento de Geografía de la Universidad de Durham. Para mí es un privilegio el que ella esté aquí y además el hacer su presentación, porque reúne lo que, a mi entender, es la Sociedad Española de Epidemiología: excelencia, multidisciplinaridad y capacidad de influencia institucional. Clare Bambra cuenta con una formación de base de Ciencias Políticas por la Universidad de Birmingham y de Política Pública Comparada por la Universidad de Manchester. Dicha formación, junto con su formación de posgrado y su experiencia profesional en el ámbito de salud pública, han contribuido sin duda a convertir a Clare Bambra en uno de nuestros referentes en investigación en salud pública y en epidemiología en general, y los determinantes sociales de las desigualdades en salud en particular. Sus proyectos y diversas publicaciones, libros, colaboraciones en informes de relevancia, como su contribución en las revisiones Marmot sobre las desigualdades en salud en Inglaterra, ilustran el exhaustivo recorrido que ha realizado por los diferentes determinantes estructurales e intermedios que generan las desigualdades en salud, como, por ejemplo, las desigualdades en salud y otras conductas que afectan a la misma. Estas publicaciones contribuyen sin duda a construir un discurso público más orientado a hacerse visible cuantitativa y cualitativamente la responsabilidad que tienen en dichas desigualdades los tomadores de decisiones políticas, las políticas y los elementos que conforman y dan forma a la estructura social. Pero como todos sabemos, la capacidad de influencia institucional aumenta con el esfuerzo que como investigadores podamos hacer en transferencia del conocimiento científico. Y en este sentido me gustaría destacar los méritos que Clare Bambra tiene relacionados con su participación como experta en centros de investigación de Gran Bretaña y otros países como Suecia, Noruega o Bélgica, su pertenencia a la Real Academia de las Artes de Inglaterra, su dedicación a diferentes tipos de redes profesionales ligadas al área de salud laboral, y su participación en el equipo editorial de Policy Press y como editora jefa en el Journal of Social Policy. También en grupos de investigación como el de European Union Marmot Review Research Group. Por su estrecha relación con el lema de esta edición, ¿no?, de nuestra reunión científica, la epidemiología para la salud en todas las políticas, me gustaría destacar uno de los proyectos más recientes que nuestra ponente invitada ha liderado, y de este modo que la conozcamos. Se titula Communities in Control Study y tiene como objetivo evaluar los efectos en salud y bienestar de una iniciativa política denominada Big Local, que consiste en invertir en proyectos de desarrollo local que se están llevando a cabo en diferentes localidades de Inglaterra. Se trata de un proyecto en el que la epidemiología contribuye a generar evidencias de cómo las políticas, si se plantean en beneficio de las comunidades, pueden generar efectos positivos en la salud y en el bienestar de las personas. Bueno, voy a dejar ahora que nuestra ponente tome la palabra y escuchemos por ella misma los datos de este proyecto y de otros proyectos, ¿no?, que forman parte de su conferencia inaugural. Claire, welcome again. Thank you very much for accepting doing this opening session. And well, now the floor is yours.
Thank you very much. Well, thank you very much, Carmen. I didn't really understand much of the introduction, but I'm sure it was nice as we are friends, so I trust you. And I think maybe almost as long as my talk, so thank you very much for that. It was very kind of you to invite me to come here to speak to you, especially in this prestigious position at such a big conference here in Sevilla. And I want to talk to you about the politics of health, thinking about the epidemiology at a macro level. They can't hear me. Is this better? Up? 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 Okay. I'm now shouting. Okay, so very kind of you to invite me, and the topic I'm going to talk about is the politics of health, thinking about political epidemiology, thinking upstream in terms of how we understand inequalities in health between social groups, but also in my examples today between different areas, be it neighbourhoods, regions or countries. So, what is political epidemiology? Political epidemiology, in a sense, goes all the way back to the 19th century and the pioneering work of Virchow, the German physician who did a lot of work in the Prussian Wars and so on, and he argued very much, as many of you may know, that medicine is a social science and politics is nothing else but medicine on a large scale. So even almost 200 years ago, physicians, epidemiologists were beginning to understand that the work that they did on the ground as clinicians was in fact massively impacted by the decisions that were being made by politicians. In Virchow's case, this was very graphic because he was looking at particularly the effects of war. But we can also think about it, the political epidemiology, how politics influences the health outcomes which we then study in public health today. Now, political epidemiology itself, as a phrase, has very Spanish roots. So literally, Carlos Alves did an editorial about this in the Journal of Epidemiology and Community Health, perhaps about 10 years ago, where he talked about political epidemiology and very much sort of introduced this as a new subdiscipline. There are also very other prominent academics from Spain, Vicente Navarro and Carmen Borrell, for example, who also are within the tradition of political epidemiology. So in my talk today, I'm obviously owe a lot in terms of inspiration to my Spanish colleagues. So I want to apply this political epidemiology perspective to the specific inequalities that are geographical, so geographical inequalities in health. not so much just between social groups, but between neighbourhoods, countries, and so on. And I'll be drawing on a couple of books that I've written, one with my colleague Ted Schrecker, and one which I've just recently released myself. I'm going to talk through some particular examples of what I call health divides, geographical health divides, starting with the US health disadvantage, talking about why the US has worse health than other comparable wealthy countries. Then I'm going to talk about inequalities within my own country, looking at what is called the Scottish health effect and why Scotland has consistently had poorer health than England and Wales. My third example is the north-south health divide in England, where health in the north of England is worse than health in the south, and this has been the case for over 200 years. I understand that in Spain, it's the opposite, that the north is better and that the south is worse. But the point is that these geographical inequalities, regardless of which way it is, are something that are consistent across different countries. And obviously I'm going to look at the specific case of England, but I think some of the reasoning, some of the theoretical side of things will be relevant to other places as well. And then my fourth example will be to look at neighbourhood level inequalities, thinking about why it is that some neighbourhoods, even if they're only a few miles apart from each other, can have radical differences in health of up to 20 years difference in life expectancy, for example, in somewhere like New Orleans or Washington. I'm then going to talk through some of the conventional explanations, so the explanations that have traditionally come from social epidemiology and from my own subdiscipline of health geography, and thinking about how they explain these different health divides, the US, the Scottish, the North and South, and the neighbourhoods. And then I'm going to go to the macro, and I'm going to talk about what more we can learn about the causes of these inequalities when we start to apply the political epidemiology lens and think actually a little bit further upstream about what might be causing the problems that we're dealing with, particularly those in public health practice, downstream on a daily basis. So, I want to start with the case of the US. So the US has consistently had a health disadvantage since around just after the Second World War. And so the US has gone from being effectively the tallest and the healthiest population in the world to being one of the fattest. Sometimes it competes with Mexico. But amongst high-income countries, the status of the US has slipped radically in terms of its relative position in terms of health. And if we just look here on this graph, this is just showing obesity rates for women since 1980 up until fairly recently. The United States is the black line, and we can see that it starts off doing fairly okay relative to other countries, and then we have this very rapid increase, so that now it's looking almost double the majority of other comparable rich countries. So this is in quite a short time frame, probably something we're all familiar with. Other countries like England and Spain are also now experiencing an obesity epidemic. But in a sense, the US kind of went first, and it's having a big impact on its relative health standing. There are, of course, inequalities within the US in terms of obesity rates, and this map is just from CDC, and it's showing how over time you get an increase in the prevalence rates of each state in each 10 years. And we can see that basically over time the different states become darker and darker green as the prevalence gets higher and higher. So we have some places that have a very low prevalence in the 90s, but we have everywhere has a very high prevalence in contemporary times. And of course the map also shows is that there is a higher prevalence rate in the south, in the southern states, the poorer states, the states of the old Confederacy. So we begin to see this idea of regional variations in health, even in this example here of the US. So if we look now at the ranking of the US, we can begin to see how this US health disadvantage has come to be something quite significant. And indeed, I was involved in an inquiry that was led by the Institute of Medicine in America, which was looking very much at this question because it's becoming quite a pressing concern for them. And indeed, it's a concern in terms of not just public health, but also in terms of things like productivity of the workforce and their future economic standing. So we can see here in this, it just shows the rankings of countries. We're looking at kind of the richest 19 countries, and we can see from 1960 through to 2010. And we can see here that the US has never done particularly brilliantly relative to other countries. But we can see that over time, the US begins to slip down so that by the 90s, it's get down, and now it's at the bottom of the list of, let's say, the 20 highest income countries. And we have to remember, of course, that the US is the most wealthy of the countries on this list, but it's doing the worst in terms of health. You can see another example here, perhaps in some ways even more telling actually, is that this is the infant mortality rates 2010. We can see Iceland and Japan, Finland doing the best at the top there, so this is the lowest infant mortality rates in the world. But we can see right down here again, the US, just like with life expectancy, is here and doing the least well. There seems to be a typo there for Switzerland, for which I apologise. Definitely not 80.8. I think there's a problem there. Ignore Switzerland. But for the US, we can see it's 6.1. And that's almost 3 times the rate in Iceland and about 50% higher than the average, not that one, the average of the other countries. So US children are much more likely to die before age 1 than children in other comparable countries. And this US health disadvantage is fairly consistent across the major causes of death. We can see here all-cause mortality much higher, CVD deaths, deaths from injury particularly, rates are almost twice that of similar countries, and deaths from diabetes, which perhaps links back to the obesity epidemic, obviously considerably higher than other countries. The only area where they're doing, one might say, okay, is around cancer deaths. And then we've seen this data on obesity as well already. So the US health disadvantage has emerged in the post-war period. It started to get worse in the 1980s. And we're now in a position where the US has gone from being the tallest and the healthiest, say, in the 1930s, to now being the most unhealthy and indeed the most overweight and obese. So my second example is looking at inequalities within one country, or rather between the countries of the federal, in effect, the federal United Kingdom, and to look at the Scottish health effect. Now, in Scotland, we find that the life expectancy between Scottish people and English people is a difference of around 2 years. And there's been a lot of work trying to explore how this has come about. And this inequality really, again, pardon me, similar to the US, really started to emerge in the post-war period. And we can see here in this chart that here's Scotland with life expectancy for women and men. And we can see how it's a couple of years lower here compared to England and Wales. But we can also see that for women, for example, we've got a 4-year difference between Scotland and Spain, and we've got a sort of 3-year difference between Scotland and Spain for men. But here in this list of countries, Scotland is doing the worst, even though it's, you know, a highly developed, high-income country. This chart here shows how, particularly for men, we get this emergence of this Scottish health effect, of this difference between Scotland and England. And we can see how it begins in the sort of this post-war period, where Scotland in blue begins to fall behind not just England and Wales, but also Northern Ireland, which arguably Northern Ireland is actually a poorer state than Scotland is. So we see that it falls behind in the 1950s, and the research has shown that this is largely due to increased rates of cardiovascular disease, cancers and occupational related ill health compared to England and Wales. But we then get another kind of second surge in terms of the gap from again around the 1980s. And the kind of specific epidemiology, the kind of etiology here, is to do with what's been called diseases of despair. So from the 1980s you get a big increase, particularly amongst younger men, in things like deaths to do with violence, deaths to do with drugs, and also indeed actual suicide rates. So we've got the kind of legacy of the cardiovascular and cancers, and then we get a kind of uplift in the Scottish health effect from the diseases of despair. So again, this is a consistent gap. It's been long-standing. There are different kind of epidemiological causes, that kind of clinical and proximate level. But we need to be thinking about how we'd explain it at a more social and political level. Now, just as with the US health disadvantage, we don't want to pretend that Scotland is just one place. There is a lot of variation and spatial inequality within Scotland as well. And we can see this here, which is just a map of life expectancy. The green areas are those that are doing better than the average for the country. The yellow are those that are roughly around average, and the red is the areas that are doing worse than average. And we can see that it's largely the west central areas of Scotland. So this is very much clustered around Glasgow. Whereas in contrast, we can see the kind of Edinburgh area and indeed the Highlands are doing a lot better. So it's not always a consistent Scottish effect, and some people have argued that in fact we should really be talking about a Glasgow effect. And of course we also think on a map like this, what we don't see is a population density. So the population in Scotland, the majority of the population live in the two urban areas of Edinburgh and Glasgow in this belt round here. So whilst these areas are much bigger, they've actually got fewer people. Now my third example is my kind of personal favourite, and this is because I live in the northeast of England near Newcastle, and this is of course what we very famous in England is this idea of the north-south divide, not just in health but in everything. And it's, I don't know, maybe it's the same in Spain, but a big kind of cultural thing to be from the north or to be from the south. Often we'll get newspaper reports and TV shows about how northerners are supposedly different from southerners. So it's a bit of a cultural trope, but there is also data very much, as I will show you in a moment, to back up from an epidemiological perspective the fact that people are living in rather different epidemiological life worlds if you're in the north or the south. Now we have a little debate in England about where is the north and where is the south, and perhaps this is an argument you're familiar with. So in my book I've done a little map showing all the different debates, and don't worry, I will not go through them with a Spanish audience. This will be a treat for my English colleagues. But the different ways in which the north can be divided. But I always go for this darker shaded areas where I would argue the north is culturally. And as I said, I live up here in the what is called the far north, in the Newcastle and Durham area. And what I want to show you is that this division is not just cultural, but it's also important in terms of the really important matters that we focus on, which is the matters of life and death. And so this map here just shows, again, this idea of worse than average, similar to average for the yellow, better than average for the green. This map is actually for life expectancy for women, so we can see that the south is doing better than the middle, which is in turn doing better than the north. So we have a socio-spatial gradient. It's not just a matter of north versus south. It actually changes at almost every level at which you go up, you travel up the country. And as I said, this is for female life expectancy, but the north-south divide is so consistent in England that really I could tell you that this map is for any disease outcome. If I did this for cardiovascular deaths, it would be the same colours. if I did it for smoking rates, it would be the same pattern. It's a very consistent division, and one that amounts to a 2-year difference between people on average living in this big region of the north compared to those living in this big region of the south. And just to sort of put this in a more international context, we can see that these regional inequalities in health in the United Kingdom are the biggest in Europe. So this is the difference in mortality rates between the regions with the highest and lowest mortality. So in England, this will be the difference between where I live in the northeast compared to the lowest rates which are found in the southeast. And we can see that our gap is over 200 deaths per 100,000, where Spain is in the middle there with over maybe 125. And then we can see that some places there are much smaller regional inequalities in the neighbourhoods. So the north-south divide in England is the biggest regional inequalities in Europe. Spain's south-north divide is somewhere within the middle. Interesting, I mean, look at Germany, and I will come back to Germany later. But let's remember that Germany was a half communist, half capitalist democracy until 1990, but there are lower inequalities there than there are currently in England. Now, the extent of the north-south divide is not just one in terms of its current epidemiology, but also in terms of the historical nature of the north-south divide. So this chart here is from a very famous report from 1842, which you might have heard of in terms of the kind of history of public health. So it was a report by Edwin Chadwick on the health of the labouring classes in England, it was called. And he was commissioned by the government to inspect the social conditions and, of course, the health conditions of people, particularly in the north of England, but also into Scotland. And his report, when he reported, eventually was very influential in Britain and led to the 1848 Public Health Act, which had a lot of work around sanitation and indeed set up the first medical office for health. So it was a really fundamental report in terms of the history of public health, not just in England, but I think also as a kind of pioneer across Europe. But for our point today, we need to look here at the data which is showing us differences across the areas in the north and the south. And this data is from the 1840s. So here we've got life expectancy for what was the highest social class at the time, the kind of gentry and professionals, all the way through to labourers. And we've got them for countries, they're rural and agricultural, but they're in the south. And at this time we can see then the difference with the urban and industrial. Some in London, but the majority of them are in the north. And we can see here that your life expectancy varies, even if you're in the highest social class. So Bath in the 19th century is a spa town, it's very prosperous, it's surrounded by beautiful countryside, largely an agrarian workforce. And we can see here that if you're a member of the gentry, you're going to live till 55. This is all for men. Whereas if you're living in somewhere like Liverpool or Manchester, which was at the heart of the Industrial Revolution at that time, then the life expectancy, even for the highest social class, is 20 years less. Now, a lot of this gap is to do with differences in infant mortality and mortality rates of children before age 5. But nonetheless, we end up with very stark differences. And it's consistent across the social classes. We can see differences here. And we can also see differences in terms of, for example, the lowest social groups, so labourers, we've got 25 versus only 15 years average life expectancy for labourers in Liverpool, 17 in Manchester in the 1840s. So this north-south divide has an interesting consistency across the epidemiological transition. So if we think of the changes from infectious disease to chronic disease, which in Britain happened in the early 1900s arguably, the north-south divide, albeit less stark today, has survived these changes, and we now have a north-south divide in chronic disease, just as 150 years ago we have the first data on the kind of north-south divide in infectious diseases. And I wonder, I'm afraid I don't know enough about Spain, but perhaps that's also a pattern that exists historically with your south-north inequalities as well. So the north-south divide is very consistent. And I just wanted to share with you a couple of more innovative visualizations that my team have been doing for me to try and show, particularly to members of the public, the north-south divide in health today. And those of you that have travelled to England might recognise going up here on the train. This is the train line from London up to Newcastle, and this is the one down to the southwest and up here to Manchester. And you can see this is the data for life expectancy for women. It shows that there's different stops on the way up. You can see the change, particularly in the northwest, from being at the kind of highest levels of health through to some of the lowest. So it's just a different way of trying to show to members of the public particularly how we can visualise the north-south divide. Another perhaps more fun way was when I did this Public Health League. Got a lot of attention in the newspapers, and in some places you wouldn't normally expect to get, at least in England. Some of the right-wing press actually published me talking about health inequalities. And what I did here was I ranked football teams in the Premier League by health statistics. So we've got things like death rates, we've got life expectancy for men, female life expectancy, alcohol-related hospital admissions, and this is for the health inequalities within the areas. So the data comes from where the football team is located. So if it's Chelsea, then the data comes from the local authority in which the Chelsea football ground is based. And what's interesting, we get a big ranking of health by this, and then we have these teams being relegated. And of course, these are some of the top teams in England. Some of them play in the Champions League. But in terms of health, they're right at the bottom. And also, some of you who are keen will see that actually this is exactly the same as if I'd done the same data if I was Edwin Chadwick. If he'd done me a football league, he would have had Liverpool and Manchester relegated from it. So the consistency is there over time. Now, my fourth example is one which will be very familiar to a lot of colleagues here, as I know a lot of you are tackling these issues locally within Seville, Madrid, Barcelona, and so on, is this issue of how and why is it that health can vary so much within a really small distance. So looking at differences in neighbourhood level health inequalities. And I just want to sort of say, here are some examples from England which really show quite starkly how health can differ in a very short space. Now I call this All Cities Have a North, referring back to the north-south divide, but in your case you could have All Cities Have a South, just kind of trying to think that some areas are always worse than others and it almost doesn't matter where you are. So if we look here, this is Liverpool, where I've talked about before, it's got the worst overall health, but we can also see that there are differences. This is looking at one of the metro lines in Liverpool, and we can see how life expectancy varies. We've got 80 dipping down to 74, 73, down and then going back up again. So we've got the kind of suburban through to the centre of the town and back up again. And of course, we can begin to think about why we might get these patterns when we come to the next section, which reflects on social epidemiology. This is Newcastle, as I said, near where I live in the northeast, and we can see this is looking at healthy life expectancy for people aged over 55. So how long at age 55 can we expect you to be disability free? And we can see that if you live up in the suburbs, which is near the airport, which is where I flew from on Monday, then you're going to live roughly 20 years disability free at age 55. But we look down here, which is Byker, which is quite a notorious district, one of the poorest, for example, then you're going to get less than 10 years. Now this journey on the Newcastle Metro is only about 10 minutes, but you're looking at a sort of 10-year difference in terms of healthier life expectancy. Perhaps a more famous example comes from the London Health Observatory, where they looked at here. This is the Jubilee tube line, which some of you may have been on when you've been tourists in London. And we can see the gap in male life expectancy between Westminster in the centre and Canning Town in the east is 7 years. And this is the famous kind of 7 stops, is a 7-year decrease in life expectancy. So these places are only a few miles apart. This is not just an English problem. It's a problem that we all have and that we all share. And here's just a couple of examples. This is the arrondissement in Paris, and it's showing, areas that are better or worse than average. And interestingly, if we think about historical patterns, we get this same historical pattern from some of the early data from the 1800s in Paris as well about the spatial inequalities in health. So we can see the differences in neighbourhoods very close to each other. It provides a different tourist experience if you think of life expectancy in the Louvre area compared to where Moulin Rouge is, so you get a 4-year difference. Here we can look at, Here we can look at Berlin. We can see the areas of the east doing slightly worse than the traditional west. What's interesting about Berlin, and we'll return to it later, is that this gap here is only around 2 to 3 years. In some towns and cities, it can be up to 17 years. So where I work and research, there are some towns there where the gap between the poorest neighbourhoods and the richest neighbourhoods in life expectancy for men is a very huge 17 years, and unfortunately increasing as we go on. And just a couple more, I won't go through all of them, but this is thinking about inequalities in Washington, in the US, again using a travel system, and this is in Sydney. We can see a variation. The point I'm making is that these health inequalities between neighbourhoods are ubiquitous, they're universal. All cities, in a sense, have a north. So how have we, collectively, alongside sociologists and geographers, so epidemiology, social geography, how have we tried to explain these different types of inequality? How have we explained the link between where you live and how long you live, this link between health and place? And conventionally, we have looked at two kind of main things. We've looked at who lives in those areas, be it a country, a region, or a neighbourhood, thinking about these compositional factors. And then we've also looked at the context of those local environments. So taking the compositional factors to start off with, then it seems quite simple epidemiology today to say, well, obviously, if you have a neighbourhood that has more elderly people, you're going to have higher health needs in that population. Gender differences in health might also impact on health in a particular neighbourhood, location, etc. We have a lot of research now which suggests differences by ethnicity in health, in terms of immigrant status, if you're Roma, for example, in Spain, so if you have neighbourhoods that have a higher proportion of, say, Roma, or African American in the US case, or Bangladesh, for example, in the English case, then on average the health of that population, and therefore that neighbourhood or country, etc., will be lower. We mustn't forget also issues around behavioural factors. So if you have a population where there's higher rates of smoking, where there's higher rates of drinking and other risky health behaviours, then naturally those areas will on average have worse health. This is a factor of the kind of an effect of the compositional nature of the population in that area. And then of course we talk about issues like deprivation and poverty, and I've mentioned that in passing. So social epidemiology also has led us to understand immensely the effects of deprivation on health. So if we have areas where we've got higher concentrations of people in, say, manual work, or with lower income or lower education, then on average the health of those areas is going to be worse. And it might be through to literally to do with material deprivation. There's a lot of research, of course, around the psychosocial effects of being poorer, living in a neighbourhood and being surrounded by other people who might have less resources than you. And then also we have this interaction between socioeconomic status and behavioural factors. So the compositional argument, particularly from a geographical perspective, has argued that it's a kind of poor people, in a sense, make poor health in a place. So poor people equals poor places. And there's a bit of a debate, because on the other side you'll have people arguing very much that place isn't just about the people that live there, but also about the place itself. And so there's a huge sort of amount of geographical research into health which looks at contextual factors. And I noticed in the programme that there are a number of studies in the Congress over the next couple of days that indeed look at some of these contextual factors, such as air pollution and the physical environment. So there's a lot of research showing that if you live in a city or a neighbourhood that has higher rates of air pollution or traffic and so on, then your chances of certain diseases and indeed your overall mortality risk is much higher. There was a recent report which caused quite a lot of attention in Britain about a year ago, where it was shown, modellers at King's College London showed that around 10,000 deaths a year in London could be attributed to the pollution levels, particularly in the summer, from traffic and so on, that happen in London. So we need to think about the physical environment, but we also need to think about the socio-economic environment. So whilst it's harmful to your health to be individually unemployed, so that would be a socio-economic compositional factor, it's also studies to show that it's harmful for you to live in a neighbourhood where there are higher rates of unemployment. And we can also see this in terms of things like access to services, so thinking about research on the obesogenic environment, and access to other services which may vary spatially in terms of, for example, access to healthcare. And I just want to think through this composition and context when we come back to the examples. So composition is saying it's poor people. The contextual argument and the research in that area is saying that it's about poor places that lead to poor health. There's been a big debate in geographical research over the last 20 years, arguing which one is more important than the other. And they've come to some kind of agreement that actually there's an interaction. What I want us to do slightly later is to actually think a little bit higher than that about what might be fundamentally determining that, and that's when we'll return to the idea of political epidemiology. But just carrying on for now with the conventional approaches, how do conventional approaches explain the different inequalities that I've been talking about? So if we start by looking at the effect on neighbourhoods, then I want to give this example, which is from where an area near where I work. So this is my university in Durham and in Newcastle. And this is the study site, which is called Stockton-on-Tees. And this is the area where there is a 17-year life expectancy between the richest and poorest areas. You can see that the dark areas are the most deprived neighbourhoods, and the stripy areas are the most affluent neighbourhoods. So here, these are almost next door to each other. That's a distance of less than a mile, and we're looking at such huge inequalities. So my team have been doing a health survey there to try and explain, using some of the different measures, so looking at some of the compositional factors and some of the contextual factors, to think what explains these big health gaps. And we've looked at various measures using self-reported general health, physical health, and quality of life. And what we've found is that, yes, you get an effect of behaviour, you get an effect of the psychosocial material, but you also get an effect of the environment. Perhaps most importantly, though, from a conventional explanation, is that you're getting a lot of interaction between the environment and the material, or the behaviour and the material. So you get a confounding effect. If you're poor and you smoke, it's going to have a worse health effect than if, for example, you're more affluent and you smoke. So this is beginning to say that, yes, it is poor people and poor places if we think in those conventional terms. So how does conventional public health, social epidemiology, health geography help us explain the north-south divide in England? Is it a case of the north, the environment of the north, or is it a case of the northerners themselves? So are the northerners less healthy? Do they have higher obesity rates, or is it because they're exposed to a worse physical environment? And to some extent, just as with my neighbourhood data, the evidence suggests that it is again a combination of the two. So obesity rates are higher in the north, smoking rates are higher in the north, behavioural factors are generally worse, teenage pregnancy rates, etc. are worse in the north than they are in the south. But you can also find evidence that some of the environmental factors are also worse. So this is an example here of exposure to brownfield land. And we did a study at Durham University which looked at how exposure to brownfield land varied regionally, spatially across the country, and also what effect that exposure had in terms of people's limiting long-term illness. And we find concentrations much more the case in the north than in the south due to industrial legacies. So you can begin to touch the surface in terms of explaining the health divide between north and south if we look at conventional explanations. Similarly with Scotland, there are big differences in terms, and of course in Scotland we are particularly looking, the gap is particularly amongst men rather than amongst women between Scotland and England, and there is a culture of drinking particularly high alcohol, quite strange alcohol. You can't actually buy this in England, but in Scotland it's a very popular fortified wine. And they also have kind of flagship things which we in England are a bit kind of joke about a bit rudely, but things like deep fried Mars bars. So you have a Mars bar and then you fry it like you fry chips. So there's a big kind of argument being made that the Scottish health effect is due to the diet of people in Scotland being worse than the diet of people in England, smoking, alcohol abuse rates are higher. So there is an argument around that. But there's also been evidence on the more contextual side, particularly looking at things like the effects of deindustrialisation, particularly within that west coast of Scotland, and the effect that that's had on things like employment chances, and then looking very much at the actual kind of almost clinical etiology, and we've got a shift in the diseases and that emergence in the 1980s of the diseases of despair, of suicide and so on, and arguing that that's related to the loss of a kind of social role, particularly for men, because of the experiences of mass unemployment in the 80s. So again, we get this debate between whether it's compositional or whether it's contextual in nature. The final example, looking at how do we explain the US health disadvantage in these kind of traditional terms. Then again, there are studies, obviously, we've looked ourselves at the obesity rates being so much higher. Education of the population in America is generally lower than countries in Western Europe, so students leave school with lower levels of attainment and so on. And poverty rates are much higher. So, for example, the poverty rates in the US are roughly twice those in Denmark, for example. From a more contextual perspective, then we have issues, the whole idea of food deserts, so neighbourhoods where it's almost impossible to buy any healthy food is very much a US big city phenomenon rather than a European issue. Issues around things like the walkability of the urban environment, again a problem in the US, literally neighbourhoods with no pavements, like whole suburbs built entirely for cars where it's actually almost impossible and certainly not encouraged to walk, for example. And then there's the kind of bigger issues around kind of social cohesion. So the US population are far less likely to vote than European populations. You have much later kind of integration of minority groups. So for example, Nancy Krieger at Harvard did a study showing that after they got rid of the segregation laws in the South, the infant mortality rates amongst the black Americans decreased massively within a very short time frame, because they then began to get access, for example, to welfare benefits and also to better healthcare services. So the kind of integration of social groups can have a big impact from a contextual perspective. So again, we get this interplay of the compositional and the contextual. But what does political epidemiology have to offer to this debate and to the explanation of these case studies? And I want us to think in terms of the idea of a river, where we can think of the very clinical and acute causes of a disease. So for example, if we took cardiovascular disease, then one of the clinical causes might be something like hypertension. That in itself might be caused, for example, by smoking or a poor diet. So that's the compositional level. In turn, this could be caused or at least associated with the contextual nature of the neighbourhood, perhaps poor access to food, healthy foods, for example. And then we want to go up here, what we call going upstream, to think actually, why are people living in these different neighbourhoods? Why do we have this kind of this spatial inequality, not just in health, but in the social determinants of health? And that's when we begin to think of this macro or political idea. And my argument is that if you put something unhealthy or polluting in the river at the top, it is going to go all the way down to the bottom. So what are the politics of health, and how does that matter in terms of these geographical inequalities? So politics, in a kind of crude sense, is about who gets what and when do they get it. So politics is always a debate about resources. And I think we need to think not just of healthcare as a resource, but the actual health of populations as a resource, which is something that is effectively debated over, albeit in the background. So if we think of the social determinants of health, the things I've been alluding to, housing, employment, things like that, these are all themselves some of the biggest issues that politicians discuss and that different political ideologies will have different perspectives on. So when we start thinking of health, we should think of health as, in a sense, a commodity, a resource, which is in itself impacted by political decisions, because they in turn lead to particular policies, which then result in our going all the way downstream. And it's not just a matter of the politics of healthcare, which I think we all understand, but it's actually the politics of public health, the political epidemiology that we need to think about. And I just want to apply that kind of thinking across to my 4 case studies. So if we go back here with the US health divide, how does politics in its kind of broadest sense of the political institutions, how they shape society and the nature of society that we have, the rights that people have, the integration of different minority groups, how does this perhaps begin to explain why the US has done less well in the post-war period than other countries? And I call this the rules of the game. It's some work that I did jointly with Jason Beckfield from Harvard. And we went through and started thinking about what are some of the more macro political differences between the US and European countries that could be explaining this gap in health between this US health disadvantage. Now, of course, this is drawing on the work of Wilkinson and Pickett from a spirit level. And one of the issues, of course, is that the US has much higher income inequality than other countries. We can see it standing out here. And this correlates across to the index of health and social problems. So they showed very compellingly in their work this relationship between income inequality in a country, and they've also done it in cities and regions, and how that impacts on the health outcomes of a country. So the US has issues around income inequality, and we know that income is something which is highly political. It's about the redistribution of wealth, it's about taxes, it's about services, it's about what's being debated all the time by political parties, and this is how it plays out in terms of health. So the US is doing badly there. There's also research showing that if you have higher levels of trade union integration, then you end up with better social determinants of health. So countries with higher trade union rates are also those same countries that have a more extensive welfare services, that have higher wages, because people have better rights in the workplace. It also plays out into other things like occupational health. So in countries like the Nordic countries, where we have much higher rates of trade unionism, you also find much more stringent occupational health and safety law, including looking at things like the psychosocial work environment. So if we apply this across to the US in terms of a kind of strength of the labour force, in terms of that political debate between capital and labour, then we can see that they've always been weak, and they're getting weaker and weaker. We can also see in my own country the huge decline, largely associated with a decline in public sector employment. Whoops. So we talked about the issue of alluding to welfare services. We can see that whilst the US, for example, spends the most on healthcare, it's 18% of GDP compared to around 6% in the UK. This doesn't cover everyone. So even with Obamacare, there's still 33 million Americans that do not have health insurance. So we can see that how that might play through. But we can also see it in terms of the wider welfare provision and how that has changed over time. So in the US, it's much harder to get entitled to unemployment benefits. It's a lower rate than you would get in most European countries, and it's also for a time-limited period. And you might only be able to have it on a couple of occasions. So it provides a radically different social and political environment. And the final kind of aspect to think about is this idea of public health regulation. So there's been research done by De Vogel that's looked at the deregulation of fast food, so the increased availability to market fast food, less kind of focus on health education around calorie content, publicity and so on, nutritional information. And you see that through from the 80s, the countries with the highest amounts of deregulation end up with much bigger increases in consumption of fast food, and indeed correlated to increases in obesity and other related outcomes such as diabetes. So if we begin to think upstream, then we can begin to see that the US health disadvantage is something that's not just impacted by these kind of compositional factors or the context of local neighbourhoods, but it's also right up there with not just contemporary, but also historical political balances of power. You know, why does the US have a poorer welfare state than the European countries? Is a discussion about why does the US not have a social democratic party? Why does the US not have strong trade unions? And we can see this playing through into the social determinants of health and indeed these health divides today. Sorry, I just skipped forward. And I want to talk about the Scottish example, where we can think about the rise of the Scottish health effect and how that's related to what could be called this idea of the shock doctrine around the massive implementation of neoliberal political economy in Britain in the 1980s, and the particular effect that it had in areas of Scotland. And this is the argument of Sheik Collins and Jerry McCartney from Scotland, and they've talked not just about the idea of the deindustrialisation, because other European countries experienced deindustrialisation, northern France, parts of Germany and the Ruhr, but they don't end up with the same negative health effects as we see in Scotland, with this increase in the diseases of despair. So this is a very famous picture of Mrs. Thatcher doing what the newspapers called a walk in the wilderness. So Mrs. Thatcher was the Prime Minister in Britain from 1979 to 1990, most associated with the implementation of neoliberalism. And here she's surveying the destruction of the engineering companies in the northeast of England. And this site now is actually the site of the medical school for Durham University. So in a sense there's a happy ending, but it took about 30 years to get there. And the area is also, Stockton-on-Tees is where we've got this big 17-year gap. Now, the Thatcher project, the Reagan project, and similar projects in other European countries was about rolling back the state, shrinking the state, and decreasing what they would see as people's reliance on the public purse in terms of things like welfare benefits and services. And in the UK, this had a big impact on the industrial areas particularly, so in the northeast where I live, and in Scotland, particularly in the west coast of Scotland, where there's a lot of heavy industry. And then the government decided that they were no longer going to support or subsidise this industry, and they would let it just compete, and eventually introduce programs that closed a lot of the industry. So you get a lot of the steel yards, for example, in the west of Scotland closing. And it was stated by the governor of the Bank of England at the time that unemployment in the north and in Scotland was a price worth paying for lower inflation in the south. So it was a very ideological project in England and Scotland, and it was one where there were very few safeguards put in. So compared to other European countries, where there was a lot more support in terms of finding alternative employment for the thousands of people who were laid off almost overnight, there was very little of that kind of compensatory measures in the UK. And this graph just shows, this is an index from the Fraser Institute. They're a right-wing think tank, and so they measure what they call economic freedom, which is the economic freedom of corporations, not our economic freedom as workers. And they show how it increases in the UK, particularly during this period of the 80s and early 90s, and there's a slight decrease with the emergence of a social democratic government in the mid-2000s. So we have a clear increase in neoliberalism. And what effect this has is that there's also changes in terms of things like tax rates. So the wealthiest people in the UK start paying lower taxes, and we get this massive concentration of the wealth that they have. And you can see that in the post-war period, where there was a stronger, more social democratic welfare state, so in the pre-Thatcher period, you get a decrease in the percentage of wealth that is held by the 1%. And then from the 80s onwards, we get this massive and continually increasing now, this is the trend line, a concentration of wealth amongst the top 1%. And just to see how this plays out in terms of health, this is looking at the neighbourhoods, so it's the most and least affluent neighbourhoods, and we've got the same time period. We can see that we get a relative decrease in this period in terms of the health gap, and then most significantly a big increase in the gap between the richest and poorest neighbourhoods, again in this period of the 1980s. And of course this is something that we can relate back to in terms of our other case studies. And McCartney and Collins have argued that this is a neoliberal attack on Scotland, it's a political attack, and that the Scottish health effect should be seen as a political health effect. And it's something, the diseases of despair are in turn caused by these social and economic policies that effectively abandon Scotland. And they further argue that actually that's what led to the rise of a Scottish nationalism, which of course is now playing out within the UK context. Now I mentioned the case of Germany before as being very interesting, and I want to kind of reflect on what Germany can teach the English about their north-south divide, and indeed Spain about the south-north divide. So in Germany, as I mentioned, and of course you all know, through to the 1990s you have this big split between a communist East Germany and a liberal democratic West Germany. And this is life expectancy for men in this period from 1960 through to about 5 years ago. And of course we've got this crucial period of 1990 when we get reunification between the East and the West. And what you can see is that East Germany declines, life expectancy for men decreases during the period of totalitarianism, and then after reunification you begin to get a very clear closing. So the gap here is about 3 or 4 years, and now it is less than 1 year between men. The kind of German story is even more compelling because we can see here a similar sort of gap to men, but now there is no health inequalities between the East and the West. The gap has been completely closed. How have the Germans done this? And obviously there will be a debate about this, and I'm going to argue that they did it through some very clear social spending measures, and they did that because they had a very strong political will. What belongs together will grow together, said Hermann Kohl, and what came out from that was a massive investment by West Germany into the healthcare, getting the healthcare system up to date in the East, and also in terms of the economics. So 1 Deutschmark for 1 Deutschmark, meant that the pensions of people in the East, the wages of people in the East, pretty much doubled overnight, and so they then had more spending power than they would have had previously. And this particularly affects elderly women, because in East Germany they had a much longer working life, much more likely to work than women in West Germany, so their pensions were better. So a lot of the catch-up here is actually to do with improvements, particularly amongst pensioner women in East Germany. But this is a decision that is made at a political level, and they have a solidarity tax in where the West Germans still pay a certain percentage of their income over for investment into the East. Now, it's not all a glamour story. There was also deindustrialization, radical changes in terms of the infrastructure of East Germany. But we also can't deny the epidemiological statistics, which are showing us that what West Germany did, the Germans have done, they've solved their regional problems, and they've done it in a sort of 20-year period. So I say to England, to my own country, if they can do it, why the hell can't we? And I'm afraid the answer, of course, is to do with politics. There was a political desire in Germany, very strong across all parties, to do with effectively a form of nationalism, albeit a fairly benign one. What we find, and what we find particularly now, and of course I don't need to tell you in Spain much about this, is of course actually an increased division between rich and poor in my country, between north and south, in terms of the policies that have come out after the economic crisis, and the excuse I believe that has given politicians to further undermine the social determinants of health through something, through the effect that austerity has been having on some of the key social determinants. And austerity is very much a political choice. It's an economic project, an ideological project. In the UK, it carries on very clearly from the neoliberalism of the 1980s. And just by way of example, this is again my map of England. We can see our regions, and this is showing the reductions in welfare. At the cuts, we've had a lot of different cuts to welfare benefits in England over the last 5 years, and you can see how it's geographically concentrated. And these are all the same areas that are the poorest areas of the country, and we can see that some areas are losing up to £500 per person. This is a big decrease on the local economies of those areas. We can also see that some of the neighbourhoods down here in the south have only had cuts of, say, 50, but some of the poorest areas, like Blackpool in the northwest, have had cuts of almost 900. So there's a spatial inequality within the effects of austerity, and one that mirrors existing patterns of deprivation and mirrors existing patterns of poor health. There are emerging studies. It always takes us time, doesn't it, as epidemiologists, to measure the effects of policies like this. To put it crudely, we actually have to wait for people to die. But if we think in terms of mental health, for example, which is a more a quicker and more responsive measure, then there are studies beginning to emerge from England showing that the austerity, the welfare cuts, the cuts in terms of social services are beginning to increase inequalities in mental health, following broadly the pattern that we would expect. And that also there are increases, socially and spatially concentrated increases in things like suicide. We also know from previous research done in the 1980s in places like New Zealand about Thatcherism in the UK, and by people like Nancy Krieger about the effects of Reaganism in the 1980s. We know from those welfare retrenchment policies that inequalities increase socioeconomically and also spatially. So we're now doing the same thing, but on a bigger scale. I don't think it's much of a leap to assume that things are only going to get worse. And in the UK, our Prime Minister, one of the kind of bonuses of Brexit was that he disappeared, is that he was using the phrase around austerity that we're all in it together. And I think we can see, just with the one map, that this is clearly not the case. We're not learning about what is important in terms of public health. We can do as much evidence as we want. But I think what we really need to also do is to be advocates as epidemiologists and to think at this political level. So just my final thoughts, I suppose, bringing this all together. We've talked about 4 kind of crucial geographical inequalities in health: the US health disadvantage, the Scottish health effect, the kind of regional north-south divide in England, but also in countries like Spain, and the differences between local neighbourhoods. I've taken you through some of the conventional explanations that we have from social epi and also from health geography, and then I've tried to argue that actually we need to step upstream and think more about why we have these social spatial inequalities in the social determinants in the first place, and taking you through different examples, using our examples to try and illustrate why a political epidemiology perspective can offer us important insights into the patterns of disease. I think we can learn from the past. We have the examples of decreased inequalities in health in the post-war period through to the early 80s. We have the example of German reunification. On the other hand, we have the more negative example from a public health perspective of the neoliberal policies of the 1980s and how that's increased health inequalities. We can learn between the two. So the past is giving us, I think, very clear lessons, very clear indications of what we need to do if we want to reduce these health divides. The present, with the policies of austerity across the majority of Europe, is flying in face, I think, of the public health evidence. And when we want to think about the future of these health divides, then we need to think how we, as epidemiologists, as geographers, as public health researchers, how I think we move our evidence from a position of research into one of advocacy. Thank you very much for your attention, and I'm open to questions.
Thank you very much, Claire, for your excellent presentation about health inequalities across geographical areas within the countries, and also the role of politics in these inequalities. Tenemos ahora muy poquito espacio para hacer preguntas y sugerencias. Al menos 2 intervenciones o 3 sí que tendríamos tiempo antes de irnos a la comida. Sí que os pediría, por favor, que esperéis a que os llegue el micro para poder hacer la intervención, porque bueno, es así como ella podrá entenderla, ¿vale? Para la traducción simultánea. ¿Hay algún comentario, pregunta?
Hi, Carlos.
Thank you very much for this conference. I would like to add the important role of taxes. We will present tomorrow a paper in the conference by Nabil Islawi and my group about the effect of taxes in health worldwide, and it's impressive, really. I mean, 30% of the variance of the health expectancy in the world is due to taxes. It's explained by taxes. It's unbelievable. So we should move to the mechanisms of why these political determinants fix the social determinants, because political determinants are the cause of social determinants.
Absolutely, and I'll be very interested to see your presentation tomorrow. Carlos was thinking about the role of taxes and some research that his group has done, which has suggested that around 30% of inequalities globally could be related to differences in tax rates. And of course, in my graphs there, I was showing the big accumulation of wealth amongst the top 1% in the UK during a period in which tax rates were rapidly cut. Countries that have more tax revenue are able to provide better welfare services, and we can see that very clearly in the Scandinavian countries. So I would completely agree and look forward to hearing more tomorrow.
Thank you very much, Claire, for your presentation, and thank you very much to the Congress for the invitation. Sorry. Manuel Franco de la Universidad de Alcalá. My question is, you presented very beautiful examples, and if some people here in the audience, we are working at the city level, and we have right now several cities that are more prompt to be listening to epidemiological data and public health interest. So what is your call or your ideas to work at the city level or neighborhoods level?
Yeah, I'm not that familiar with the kind of devolution of power that you might have at the municipal level, but certainly Diana Gill was telling me about some of the work that's been going on in Madrid and Barcelona around investments in social welfare, and I think picking up on Carlos's point, it would make sense to very much focus on that, particularly in a period where you've got such high unemployment rates. I mean, when we come to thinking about how do we solve health inequalities, be it at a national or at a local level, then we have an abundance of information from a variety of reviews that have been done at the European level by WHO, the Marmot Review of Health Inequalities in England, for example. There's a very strong evidence base about how we should intervene, where we should intervene, and when we should intervene. And it's particularly within the community, and it's particularly in early childhood. The evidence is there. I just fear that we don't have the political will to act on that evidence. So if you're in a position in Madrid where you have a political party in power who want to act on it, then I think that's fantastic, and it might be a matter of going to the evidence around interventions that would help you, and there's certainly a lot out there, I think, that you could draw on.
Bueno, pues ¿hay alguna intervención más? Bueno, la última.
Hola, buenas. Bueno, yo no sé muy bien inglés, entonces no sé si ella me va a poder entender si le pregunto en castellano.
Carmen will translate for me.
Vale, bueno, yo me llamo Unai, soy residente de Medicina, Preventiva y Salud Pública, y bueno, muchas gracias por su presentación, me ha parecido muy interesante. Y mi pregunta va un poco encaminada ahora con todo el tema del Brexit, que cambia un poco todas las reglas del juego, tanto en política neoliberal como, bueno, ¿cómo crees tú que podría llegar a afectar eso a las diferencias sociales y en términos de salud que estabas comentando antes, ¿no? Porque hay como muchas piezas en juego y es como un poco difícil encajarlo todo para saber cómo van a poder ser las cosas.
So that's not a very easy one. How can Brexit affect public health and health policies in the future? I think I have a strong fear that Brexit will very negatively affect both the NHS, our National Health Service, and also public health. The majority of those politicians who advocated for Brexit in the UK were from the right, from the very libertarian neoliberal right of our political spectrum. And they wanted it because they felt they would be able to have more free trade, get rid of the regulation that comes from Europe. And obviously a lot of that regulation is exactly the sort of things that I've been talking about in terms of being beneficial for health. So for example, occupational health regulation, rights for workers, maternity leave, paternity leave, the working time directive, all these very important things that shape the social determinants of health in a positive way. I think they will be, over time, potentially removed. That the UK may well become a much lower wage economy. So those things in themselves would be negative determinants for health. And in terms of the National Health Service, so in terms of healthcare, then Martin McKee from the London School of Hygiene and Tropical Medicine has written some interesting editorials for the BMJ on this topic, talking about his concerns, which I would share, around a much more, an even stronger marketisation of our health service and the stronger incorporation of a kind of more American care pathway, managed care kind of approach. So I think it's potentially a negative impact. But of course, we have to hang on to hope. So whilst our new Prime Minister, Theresa May, who does have a very eerie kind of similarity to Mrs. Thatcher in all kinds of ways, but that's an aside. So the new Prime Minister has said that Brexit means Brexit, but we don't actually know what Brexit means. So it's still a big open box. And I guess our kind of role in public health and in on the kind of pro-European side of things more generally would be to try and make Brexit be as small as possible, I think. Thank you for your question.
Bueno, gracias también a todos por haber venido y nos vemos de nuevo aquí a las 2:30, donde tendremos la inauguración formal del evento.
Thank you very much.